Well, I wanted to once again thank our esteemed panelists and experts and for your time, and this information I think will be very valuable to the committee. And I also wanted to thank you for staying on time, and we're actually remarkably on time, so I wanted to thank you for that. And so now actually I'm going to go ahead and open up the questions first to members of the committee. Yeah, I think you do need the mic.
Yeah. Thank you, Ledson, and thank you all for a very informative and I would say getting to the inspiring level of presentation. So that's we appreciate that. Assemblywoman Yamada, I wanted to ask you, given your effort to mobilize political will and political resources and your call for champions, of whom I'm confident you are one, what you felt you were able to accomplish in terms of changing policies in particular in your work in the Assembly?
Well, I wish I could, about that. Thank you. I wish I could say that we got a lot done, but in context, as I explained, at least the time that I was in service, we were in some of the worst budget times our country and our state has ever seen, and I know each of you experienced that in different ways. I think that what we were able to accomplish, a couple of things. First, I wanted to comment that in terms of caregiving in California, there are really, the two systems. We have the in-home supportive services program, which is the largest of its kind in the nation, now approaching 460,000 impoverished elders in our state, with almost an equal amount of caregivers, a few tens of thousands less, but, and that number is going to grow. The private side, which is, I say, caregiving for the rest of us, did not have a policy framework for regulation until this year. I repeat, it is 2015, and it is the first time in California that we have had an opportunity to establish standards for the private home care industry, caregiving industry, and establish certain requirements. So I think that was probably one of the major accomplishments of the last 6 years. But, it doesn't happen just in one session. It requires sort of that continuity, which we also did not have because of our term limit situation. But that's changed a little bit. And I don't want to take too long answering your question. Oh, sure. Sure.
Do you think that you accomplished anything? I'm sure you accomplished a great deal, so I don't want to minimize. But do you think that, or can you give us any guidance in your experience on how you framed the issue, how you talked about the concerns?
Well, let me just say that I think we could do a much better job in California in terms of how we focus the policy issues that are relevant to the age groups that we're talking about. Right now, aging and long-term care policy is actually not under the purview of the Committee on Aging and Long-Term Care. It comes under the purview of the Assembly Committee on Human Services and the Assembly Committee on Health. And there are many too long stories to go through, but we continue to raise where the locus of responsibility should be, even in the Assembly, where, in a state with 38 million people and 80 Assembly members, we haven't quite figured that out. So we have not gotten there in the Senate. But I do think that the conversations are continuing, and the fact that we look at IHSS as, it's always described in the negative. It's one of the fastest growing entitlement programs in the state. Well, I'm not sure we should be proud that we have these many impoverished older adults. I mean, we should be proud that we have the program, but it's the way we cast light on this discussion that needs to be addressed. So I'm hoping to continue that work one way or the other. I like to say we're aging and raging. So let's not be polite about it. Let's rage our age, because we are children of the 60s that are in our 60s, and we didn't really much like things the way they were in the mid-60s, right? So I think we need to seize this moment. Thank you.
So this is for Dr. Crimmins or anybody else on the panel. You mentioned the role of payment, and I was wondering if, in thinking about payment, or just in general, you thought about ways in which the payment system like Medicare and Medicaid might be designed to better serve caregivers?
What I mentioned was that payment can change the game, and I think we need to be aware of that. And have I thought about it? Yes. Do I think it's likely to become a large part of those changes in those programs in the short run? No. I think that in the short run, the next couple of decades, it would be nice if we could change the system, and I would certainly advocate for that, to pay for what is the major health problem of old age. And, the fact that we pay for acute care, not for long-term care, not for the needs of people, I think that needs to change. In the short run, I think what we have to deal with is making it possible and pay for things in such a way that individuals can caregive the way they want to, because it's not just money, it's making people being able to do things and providing the money in the right places. And there are things that don't cost that may be appropriate ways to go. So building communities, using the aging baby boomers now who are younger to build small communities of people who contribute to groups and then can later take out of those groups the care. Those are people that are available to provide care for community members that might not have family members now, and they might want it later. So I think there are lots of things that can be done without money. I think it would be nice if we had a medical insurance system that was like other countries that paid for this, but I'm also realistic.
I'd like to add that in the near term, I think something could be done around looking at value-based payment, and that's where we're heading with CMS at this point. And part of the value is what do people and their families value. And so defining the quality metrics, and that's something that's very much underway with the Impact Act that came into play at the end of last fiscal year federally. The idea to really look at as we look at the transitions into the community and community-based services, how do we define value? And thinking about it as a family-based value and the family having input as a caregiver. One of the efforts underway right now is the CARE Act that's been passed in 6 states so far, and it's moving across the nation. And that's requiring hospitals to actually allow people to name a caregiver and include them in the discharge planning. That's a near-term thing, but it's really vital that people are included in the thinking about that transition to the home, because more and more family caregivers, it's not just a chronic endeavor, but it's also a post-hospital and sometimes very high technical endeavor. And people are really unprepared and not included to the extent that they should be in that very vital period. So I think there's some immediate levers within the Affordable Care Act and with the changing towards value-based payment that reframes who the target of the care is beyond the individual to include the family. And then beyond that, the ripple is around community supports and how to bolster those from a policy perspective.
I'm going to change topics a little bit and ask a somewhat odd question, which was triggered by some data that Marie Bernard presented concerning the obesity epidemic and its impact on disability rates in the future, currently and in the future. And it occurred to me, and actually for the first time, that it's harder to take care of an obese person than it is a non-obese person. And this has implications both for informal and formal care. And I was wondering if anyone is thinking about, talking about, or has written about that kind of issue. I'm imagining a frail older wife trying to take care of a 300-pound husband, and that's a challenge that we haven't really talked a whole lot about.
I think it's a very good question, and as I alluded to at several points, there are lots of opportunities for us to further investigate what the scenarios will likely be. I can certainly say anecdotally, in my other life as a geriatrician, I saw lots of examples of little 80-pound wives taking care of 150, 200-pound husbands, and doing it very well, much better than we were able to in our formal setting with our VA-based nursing home, et cetera. But it really does need some systematic evaluation, I think, and some consideration for the future.
Well, and I would just add to that, although we are focused sort of on the here and now, the implications for this in our younger populations going forward, it's certainly something that would link the generations in terms of planning.
Thank you. Good morning. That was a very informative session, and I appreciate all of your talks. It was inspiring. I have a specific question for you, Dr. Young, on your report, and it is just very specific. In terms of the 20 interventions that you identified, I wonder if you could just elaborate a little bit more about what their components were and what their outcomes were, whether, you had mentioned the stress process model as the primary focus, but whether there was any innovative approaches, and whether you also could comment about a measurement in this area.
I'd be happy to, and it'll be a very short commentary. About a third of the studies were part of the REACH program funded by NIA, and so those were very much a psychosocial educational approach. And I think across those studies we saw moderate effects, and the sustainability wasn't always really long-term, and just in a general sense. The innovative approaches that we saw, there was one study that was done among the Native American community that looked at polarity therapy, comparing it to respite, and found that the polarity therapy was something that was helpful for people essentially managing stress as well. Within the African American community, I think the most promising interventions had to do with mobilizing and trying to sustain the network, and to also bring together supports that incorporated spiritual aspects as well. So but these are, one-off types of studies. So clearly there's not a lot of robust evidence about any of them, but tremendous promise in those approaches. Measurement is somewhat uneven. I think we've, and I'm guilty of this myself as a researcher in this field, had somewhat blinders on about what we think are the important outcomes. And in many respects, I think we need to step back and really ask, what do caregivers and their families need and want? What are outcomes that are meaningful to them as we design interventions? And obviously, when you look at the needs, there's skills types of needs, there's educational needs, there's logistical needs, and then there's the socio-political, economic needs. And all of those would suggest very different types of interventions. Coupling that with the trajectory, how you sync those up for what needs to happen at the right time, again, gets back to a commitment to ask the family caregiver what right now is the salient issue and what would be most helpful. Because I think it could be very overwhelming if we sat and imagined all the possible issues and then tried to deliver something to address those. I think that would overwhelm and probably wouldn't have the effect that we would desire. Thanks.
So maybe for Assemblywoman Yamada, you mentioned that you had a rural population that you were serving, and it seems there isn't a lot of data about differences in rural populations, family caregiving. I wonder if you had any thoughts about that in your experience representing them?
Well, I know later in this morning's discussions you will have some specifics on rural populations. What I can just tell you is we did not do a specific hearing, urban versus rural last year. We were focusing more on specific, more ethnic and religious almost cohorts. But we all know that the rural areas just suffer disproportionately. They just have fewer resources Frankly, I have to be a little careful on the political statements here, but in California in particular, rural areas are generally represented by a party other than mine. And I think that while I have been privileged to represent a large rural area for a time, sort of the ability to marshal resources in a collegial fashion with some of my rural colleagues was challenging, because there are many strengths in the rural community, more family-centric supports that may not be as prevalent as in the urban areas, but rural populations are, of course, experiencing the same kind of demographic shifts as the urban settings. It's literally you have to leave the area in order to survive, and so the people who are left behind are the older generations. Unfortunately, one of the tragedies I think that occurred in California during my 6 years was the elimination of what's called the Adult Day Health Center benefit or program. It's too long of a topic to go into, but many battles were fought to restore the agreement that we had with the governor on that. That was actually reneged upon, and advocates went to court to have that benefit restored. They were able to do that, but only for a temporary period. So as that relates to the rural issues, the most closures of those, or disproportionate effect of the closures, were for the rural providers. And I am sure that people died prematurely because of that state policy decision. So, but I look forward to to hearing the positive. There are positive things happening in other parts of the country to serve rural populations.
Thank you all for being with us today. Dr. Bernard, you mentioned dementia and its impact demographically and growth. I'm wondering, do you think policy should follow disease incidence rates as a way of prioritizing our resources, or do we need to balance between risk reduction efforts for the disease that may impact the reduction of caregiving burden?
So I have to make the disclaimer that I'm a federal employee here on federal time, so I can't talk about policy. But I can certainly talk about the fact that there is in place the National Alzheimer's Project Act, signed into law by President Obama in January 2011. And there is a national plan for Alzheimer's disease that calls for us to find a prevention or a cure for Alzheimer's by 2050, but it also calls for us to approach issues with regards to support of the individual and their family and their network who's suffering from Alzheimer's disease. And there's a lot of really good work that's being done by multiple entities to try to move us forward on both fronts. If I can take off my federal hat, which I can't really do, but I'll say that I think both are really important. And it's very exciting to see all the things that are going on, both towards trying to find a prevention or a cure and trying to enhance services and to deal with the present-day realities. I don't think we can move forward without doing both.
Good morning, and thank you to everyone for a great panel discussion. My question is for Dr. Young, and I wonder if you would, given the paucity of research-based evidence for culturally competent interventions, if you would comment on the implications of that for practice. Do we wait until we have randomized clinical trial data available, or is there another could we think outside the box in terms of what we can do in practice for diverse populations of caregivers?
It's a great question. I don't think we can afford to wait. If you look at the since 1980 time frame and the window and the time it takes for translation to happen. Currently, we're undergoing a review, and it'll be done in about a month or so, of the gray literature, if you will. So we're looking now extensively across the country to see what is being done for caregivers, what are the programs that have been in place, and we're evaluating and trying to understand how much they've been evaluated in different ways. And of course, there's the range of evaluation to, the randomized controlled trial or comparative effectiveness, all the way back to program evaluation. And so we're looking at across that range. And there's some promising approaches and some robust areas of work that are going on across the country. In general, I'll say, as we map it in the United States, the entire middle of the country is missing. In terms of innovations in the communities where there's robust commitment to multicultural care. And yet we know that that's not the population demographic doesn't support that type of an approach. So we know that there's pockets of innovation. I think the way we need to do this is elevate those pockets of innovation, bring them up to a level where others can learn the lessons learned, and open up the dialogue more constructively and more openly so that people can see what is going on and have a broader way of understanding it. I think about the extension programs with agriculture we had in the past, and we've done this with IT as well, the regional programs that are federally supported. And thinking about caregiving in a regional way and with resources to elevate best practices for further testing in a much more community-based way than the traditional research engines. I think those need to happen as well, but the timing just isn't appropriate for what we need to accomplish.
Thank you again for sharing your very helpful insights this morning. This question doesn't relate to the primary focus of the committee or the work you talked about, but we are all aware that when instances of caregiving breaking down or going awry, with the result being neglect or abuse, that does occur. And I was wondering if, perhaps this is more to Dr. Young, but any of the panelists, does any of the research that you looked at provide any possible insights into whether or how the dynamics differ across cultural groups that you looked at, and what interventions have been most effective in preventing that?
It's a really good question. I think it's somewhat of a hidden issue in many respects, that it's not something that comes out to the fore. What we saw in some of the groups, particularly the Asian American group, where there was very strict expectations, filial obligation, and oftentimes that obligation is to the daughter-in-law to care for parents-in-law. And sometimes the relationship hasn't been as healthy in earlier life, and then the daughter-in-law is expected to provide the care. That's an example of a time when there can be tremendous family tension and difficulty, and that's yet not socially acceptable to say that there's that kind of a tension in play. In the Latino population, there's tensions around the economic aspects of availability to care and who should be in the first position to be able to sacrifice, in many respects, an employment opportunity to care. And so the kinds of conflicts that arise obviously have the potential to end up in neglect or abuse. The actual abuse and neglect is not often surfaced in the studies that I was able to review, but I think the potential is certainly there. And clearly the difficulties of family dynamics and making these difficult choices, often in the absence of support, and the shame and stigma associated with those conflicts, especially when we're expected to care and we're expected to want to care, and when that's not easy, it's often not as acceptable to express that publicly. So I think that is an area that warrants a lot more exploration and understanding.
I'll just quickly add, not so much from a research standpoint, but the Assembly Committee on Aging and Long-Term Care partnered with the Assembly Committee on Public Safety for a first ever joint hearing to address really the epidemic of elder abuse in our state. It is still somewhat hidden, but again, beginning to become more, I don't want to use popularized, but more in the public domain. because of investigative reports and so forth. But California is really still very much behind in terms of funding supports for adult protective services. Remember that we are about 30 years behind. For example, mandated reporting for children began in 1969. In 1999, it became mandated for elders. So it was 30 years behind, but we don't have 30 years to catch up.
Yeah, I want to ask a question of Dr. Crimmins. You talked about life expectancy, mortality, factors that affect the prevalence of both population in late life and disability. I wonder if you could speculate about immigration. I mean, to what extent are there immigration scenarios that might have a significant impact on the age composition of the population in the U.S. in the future?
There are, of course, scenarios that could do that, but the proposed scenarios in the projections that we have now don't really indicate any major change from that. I mean, certainly immigration can go up and down, and in many ways we've lived off having immigration because that has brought us a constant new labor force, young population, but all those people come in and then they get old. So it's a very short-term fix, if you want to call it that, for the change in the age structure. So I don't think it's not something that's going to be a major player. In fact, in mortality trends, while there's a range of projections, not going to play in such a way that it's going to change the outcome. The only thing that would change the outcome would be if everybody decided to have 6 kids. And you know how likely that appears at the moment. Not impossible, but we are in a situation that we will be in no matter what, basically.
Yeah, if I may, I don't mean to over-answer, but just as an insight, I did go on a California Senate delegation trip that I paid for myself, by the way, to Japan last year to study high-speed rail as well as aging and long-term care in Japan. And all of you demographers out here know that I think it is still Japanese women are the longest living women in the world that I probably remind my husband of from time to time, but he's Chinese American. So, but anyway, no. My point here is that Japan, and again, you probably all know this already, but just for anyone that may be listening that doesn't know, they are they're facing now what we will, as a nation, be facing in the not too distant future, with a negative birth rate. With about 34% of their population over the age of 65 already, mandatory retirements and so forth at certain age groups, so at a certain age. So it's kind of a laboratory, which is why I was very pleased to be able to go on this study trip. But the immigration issue, is even more pronounced there with the immigration policies that Japan has traditionally held. So, if we can take any lessons there, just one final note. In Japan, everyone at age 40 is required to purchase a long-term care insurance policy. It is not negotiable. It is national policy, has been around for a number of years. For those of you who are under 40 in here still, I don't know if we'll ever get there as a state or as a nation, probably not as a nation in my lifetime, but maybe in the state. Because what we're all talking about, as we're sitting here aging, is that we don't know how the care is going to be paid for. And there are other issues with gender pricing for long-term care insurance, that women pay more than men, and we understand, the reasons, the sound sort of statistical reasons for that. But is that morally correct, given the fact that women make less money than men over our lifetime? So it's many policy issues to be grappled with that need some close attention and very quick attention if we are able to pay for the care that caregivers that you're studying.
I have a question for, hopefully this is being captured, for Heather, for you, but others may want to weigh in as well. And it actually addresses the issue of, part of the work that caregivers do, I think, for older adults that they're caring for is help them to negotiate services through the healthcare system or in the community. And I guess my question is if you, or would ask you to just elaborate or amplify a bit more on some of the key themes that emerged from your review with respect to how caregivers experience that as they try to help older adults, and any sort of policy recommendations that might flow from those observations.
I think in the area of who's caregiver and who's recognized by the health system, that's one place that obviously many communities struggle with, especially if it's a non-traditional relationship and it's a primary person who's important. So being able to be included in the conversation and recognized is a really important policy issue, and how all of our institutions actualize that is a really big question. As far as what caregivers are trying to deal with is even understanding what's available within systems and being able to navigate our very complex web of that. And from a policy perspective, I think we have a very hard time making that visible to our communities. We tend to, as institutions, each catalog what we offer and how we offer it, but we fail to link how we offer and how we pass the baton among us. And I think from the perspective of looking at a community base with the public health departments as they do community assessments, as hospitals are required to do community needs assessments for their nonprofit status, linking those expectations I see as policy levers to force more of the question about how do we catalog at the community level, what's available, and help with that navigation in a more robust way. Because it's people learn and understand their community and their networks in different ways, but even for those who are sophisticated, it's very difficult to get accurate and up-to-date information about resources and supports. And in many cases, the Medicaid system will pay for case managers or some who will help to navigate. And if you're wealthy enough to hire that privately, that's possible. But there's a very large group of people in between who don't have the resources nor the eligibility to access that type of navigation and support. And that's an area that I think we should be looking at.
Thank you. Thank you very much. I don't know to whom to direct my particular question, so I'll just open it up to all of you. But I want to bring it back to the issue of diversity and multiculturalism. The issue that in ethnic and racial minority families, there's a larger presence of youth and children. So you have intergenerational families that are affected by this thing that we're calling the caregiving issue. Having children and youth present, whether within the family structure or extended family, neighborhood, etc., how does that affect caregiving, both on a policy level or intervention development level, demography, clinical practice?
I just want to say that when we compared across countries, grandchildren were much more involved in caregiving in the United States than other places. And about half of older people who were disabled received some kind of caregiving from grandchildren. And so I think having them in the network is absolutely important, essential, and valuable.
Generationally, one aspect is looking at who's over 65, and right now with our demographics, it's not uncommon to have 3 generations over 65 in a family, and at least 2 over 65 generations. And so who's getting care and who's giving care is a very fluid kind of an issue. The sandwich generation, it's been called, the people who are in the middle, often women who are caring both for children and for parents and grandparents at the same time. That's a group that's at particular risk and really stretched both economically and personally to be able to enact that. We're also seeing generational shifts in the way people view caregiving. For example, in the Japanese American community, where the Issei group had a very traditional view of what's expected, and now in the Sansei and Yansei generations, a very different view about what the responsibility is and how to access services. So there's a tremendous amount of complexity around the generational issues in caregiving as well.
I'm just glad you're studying it.
Well,
I would just say, very, very true what you just described, but for our own family, with this, well, we don't want to be a burden on you, right? But we told our children we plan to be, so, no. Yeah.
Well, I think our time is up, and again, I really wanted to thank all the panelists for your information and contributions. Thank you so much.